Hello everyone, very warm welcome to the video of clinical scenarios related to thyroid neoplasm. Here we are going to see various thyroid carcinomas and adenomas and what are the diagnostic features of all those thyroid neoplasm. We are going to see here. First we see uh, a 49-year-old female present with a thyroid mass and undergoes thyroidectomy. Then from this microscopic structure, what we can diagnose? First, we see what are the various features we can appreciate here. Here we can see there is a papillary like growth, and they are just demarcated by the various fibrovascular connective tissues. And also when we see the nuclear features, we can see such types of the nuclear features are present, which shows nuclear pseudo inclusions. And also we can see nuclear enlargement and orphan NI appearance of nuclei, that is ground glass appearance of the nuclei we can see here. And next we can see the nuclear crowding and overlapping. And also there is oval shape of nucleus as well, most probably. And the various calcified regions we can see here in this microscopic structure that is called as the samoma bodies. And with these features we can think of the papillary thyroid carcinoma because of papillary like growth as well. And also there is the branching pattern of the papillae. And samoma bodies are also present, and most important is nuclear pseudo inclusions and orphan eye nuclei, which are appreciated in the microscopic uh, structures earlier. And the various variant of papillary thyroid carcinoma are classic, tall cell variant and follicular variants. And along with these variants, there are so many variants, but uh, most worse prognosis is seen in tall cell variant, diffuse sclerosing variant, and columnar cell variant. And the most common alterations we can see the BRAF point mutation at the 600th positions, where there is a substitution of valine to glutamate. And you can go through the video of papillary thyroid carcinoma to see this. Next clinical scenario is a 61-year-old man present with a thyroid mass and undergoes total thyroidectomy, and the mass has a high mitotic rate and areas of necrosis. And from these microscopic features, what we can see here, you can see there is a well demarcated structure that is like a that is encapsulated or that is surrounded by the trabecular like network. And such types of growth is called as insular growth. And the hypercellularity can also be appreciated. There is just so many cells. And the colloid natures and the thyroid follicles are completely absent in this figure. And areas of necrosis can also be appreciated in such things. And the papilla like projections are also not present, so we can rule out the papillary thyroid carcinoma from this picture. And mitotic rate seems to be higher, since there is so many cells present. And also the monomorphic cells are appearing. And solid mass like pattern and insular growth are appreciated. And such things can be only seen in poorly differentiated thyroid carcinoma, especially insular type. So diagnosis we can do it as poorly differentiated thyroid carcinoma insular like. And diagnostic features what confirm these are we discussed earlier. And the convoluted nuclei, which are non-papillary nuclei. In the papillary thyroid carcinoma, we had seen there was orphan and eye-like nuclei or ground glass-like appearance of the nuclei within the nucleus, and nuclear pseudo inclusions were also appreciated. Such features are not seen here because it has, you know, gone through the poorly differentiated thyroid carcinoma, though it is originated from the papillary thyroid carcinoma, but it is a very malignant condition where papillary like features are not seen. Also, it is developed from the follicular carcinoma. And next is a 75-year-old male that presents with difficulty in breathing and a rapidly enlarging thyroid mass are also present, and incisional biopsy is performed. So in the biopsy we see such types of here, and here we can see the spindle type of the cells. Various spindle type of the cells are present here, and along with that pleomorphic giant cell can also be seen. Pleomorphic are the variable shape and size. These giant cells can also be seen, and squamoid cells are also present here, and along with there is no any colloid like appearance, and such features are also the feature of undifferentiated or poorly differentiated thyroid carcinoma, most commonly anaplastic type. So diagnosis is undifferentiated thyroid carcinoma, anaplastic thyroid type. Diagnostic features are spindle cells, squamoid, and/or pleomorphic giant cells, which we saw in the picture. And the cell of origin is a high-grade malignant neoplasm of follicular thyroid origin, and that arise from the well-differentiated thyroid carcinoma, usually papillary thyroid carcinoma. And it's very aggressive. That means more than 50% of patients can show distant metastasis at presentation, and their survival will be less than 6 months. And they show the negative. They are negative for thyroid transcription factor 1, thyroglobulin, cytokeratin, which are the thyroid differentiation biomarker. And next clinical history is a 34-year-old female undergoes thyroidectomy for a thyroid nodule, and she also has a history of multiple colorectal polyps. So with that features, what is the diagnosis here? You can see there is a papillary like growth in this sphere, papillary like growth, and but we cannot appreciate the papillary like features like orphan in eye or pseudonuclear inclusions. Such things are not appreciated, but there is a papillary like projection. So there is also cribriform pattern of the growth, and squamoid cells are also present, and there is a nest of the cells. Nest of the cells are present, and that involves a tall columnar or spindle shaped cells, and also there is a complex branching papillary structures here, and all these features are they are just signifying the modular cribriform modular variant of papillary thyroid carcinoma that generally occur from the mutation of the gene FAP gene. And the diagnosis is papillary thyroid carcinoma cribriform modular variant, and these are the diagnostic features that we discussed there, where the cells are packed into a bar arches, and that will form a nest-like structure, and that is with a squamoid appearance and presence of complex branching papillary structures, and often involves the tall columnar or spindle shaped cells. And similarly, nuclear and cytoplasm beta catenin accumulation with positive staining for thyroid transcription factor 1. And previous one was not positive for thyroid transcription factor 1, that is undifferentiated thyroid carcinoma, but this variant of papillary thyroid carcinoma is positive for thyroid transcription factor 1. And there is also haline material depositions in the feature, and hemosiderin laden histiocytes because of the macrophages that contain the hemosiderin. There is a various um, hemorrhages. Similarly, other a 29-year-old male presents with a thyroid mass and undergoes diagnostic thyroid lobectomy. Lobectomy means a single lobe, and what is the diagnosis from here? What we can see that there is a nest of plasmacytoid in spindle cells with a salt and people chromatin. There is a various nest of the cells that we can see here, and amorphous background and eosinophilic materials can also be seen, and that all occur from the calcitonin depositions, and these are also positive for Congo red stain. So all these things shows these are medullary thyroid carcinomas, and diagnostic features we discussed there, and mm, positive for calcitonin, and also carcinoembryonic antigens, and synaptophysin negative for thyroglobulin, and highly associated with MAN2, and that is caused by activating RET gene mutation. And cell of origin is malignant neoplasm of C cells. Thank you.